neuroendocrine tumors. That's a pretty big bite to swallow. I will attempt to do so, and there will be many areas in which there'll be gaps, but all of the speakers following me will fill in the details. And of course, there'll be a great deal of repetition, but that's the basis of education. And there will be opportunity to ask questions. First of all, in terms of diagnosis and treatment, originally in 1907, the term carcinoid was coined to fit these tumors, which were thought to be almost benign at that time. That's why carcinoid was the term given to them. They weren't carcinomas, ordinary cancers, but they weren't benign adenomas either. They were in between. But for years and years, and even so still in some quarters, the concept of these being practically benign tumors has persisted. But actually, 13% of all carcinoids have distant metastases by the time they are first diagnosed. And hence, with an increasing awareness of this malignant potential, the pendulum of management is swinging towards earlier and more aggressive treatment. There are a number of misconceptions, and I'm sure that many in the audience are familiar with these because they've applied to you. The misconception that it's a chronic, nearly benign condition, that it requires no treatment unless it's really very symptomatic, and then do the least you can get away with. To withhold somatostatin analog treatment until the carcinoid syndrome symptoms are very prominent, and then use the lowest dose feasible. Perhaps this concept stems from the use of insulin in diabetes, where too much is just as bad as too little, but not so here. And then a lack of familiarity with biotherapy and its use in carcinoid heart disease, or even in the absence of carcinoid syndrome. And finally, the misconception that chemotherapy categorically across the board is ineffectual. These are all misconceptions. Now, this simply indicates that carcinoid is in between a benign and a malignant tumor. It really is a tumor which has malignant potential, doesn't always realize that, but progresses at a slower rate. Now, here's a picture of a brick wall. All the bricks are the same. It's homogeneous. And that is a misconception that is applied to carcinoid and other neuroendocrine tumors, that they're all the same, all cut with the same cookie cutter, so what applies to one applies to the next, and that's wrong. Now here's a brick wall that's a little bit different. It's heterogeneous, different color, different appearances to the bricks, but they're still all the same size. And here finally is another stone wall, which is quite different, very heterogeneous, and this applies to carcinoid and other neuroendocrine tumors. They may look the same superficially, but they're really quite different in their response to treatment, in what they produce, what symptoms they may cause, etc. Now, these tumors, carcinoid, originate from stem cells that probably come from the neural crest in the embryo, and then migrate throughout the body and are sprinkled in many organs, but particularly in the gastrointestinal and pancreatic tract. In addition, they have certain characteristics. They stain with chromium salts and with silver most of the time. And furthermore, the term, you may wonder, why are they called neuroendocrine tumors? And that's because they have many features that they share in common with neural tissue, nerve tissue, yet they produce substances, endocrine substances, that play a role in the normal body functions. So they're called neuroendocrine. And here's a picture of a typical carcinoid tumor in which you can see a sort of similar cell throughout. They don't vary greatly. Yet in other tumors, other carcinoids or neuroendocrine tumors, you may see where the dark arrows are that there are peculiar differences in those in the nucleus of those cells. These are mitoses. The cells are dividing, and we like to look at the microscopic appearance and see how many cells are doing that, because that helps tell you about the aggressiveness of the tumor and allows for some prediction as to its behavior. And then we have other things that help to tell us that it is indeed a neuroendocrine tumor. Staining with chromogranin, as you see here. Those cells that are stained are neuroendocrine tumor cells. And here is a picture of the commonest type of carcinoid tumor. And I might add, first of all, we're trying to talk about both carcinoids and other neuroendocrine tumors. The other neuroendocrine tumors are not as common as carcinoid. About 3/4 or so of all neuroendocrine tumors are carcinoid. So we're emphasizing that in our presentation right now, accepting that many of the features that apply to carcinoid apply to the rest of the neuroendocrine tumors. And here is the commonest carcinoid, these little nodules in the intestine. This is a piece of intestine that's been split open, and you can see quite a few of these little tumors. That's characteristic. And here's one magnified on cross-section. And the important point, this is very small. It's maybe a centimeter in diameter. And you can see the layers of the intestine. There's the mucosa lining of the intestine covers this little tumor, so it's submucosal. And you see then in the midst of the wall of the bowel there is the muscular coat, and you see little streaks of tumor that have eroded or grown through that layer, the muscle layer, and going into the serosa, the outer covering of the intestine. This is a malignant tumor, but very, very slow in its growth. Now, some general features. Carcinoid and other neuroendocrine tumors comprise only 2% of all pancreatic malignant tumors. They are consistent of both functioning and non-functioning tumors. That means those tumors that produce hormones or active substances that have some influence on body functions and may cause symptoms, those are called functioning tumors. Non-functioning tumors are tumors that don't produce any, or probably they all produce some, but not enough to cause clinical symptoms. Microscopically, with standard staining, they all look pretty much alike. So very special staining and other markers, tissue markers, have to be used to determine just what kind of a tumor this is. Is it a carcinoid? Is it a gastronoma? Is it a vipoma, etc.? Again, we emphasize that carcinoid is often misdiagnosed. The commonest, most mistaken diagnoses are irritable bowel syndrome or inflammatory bowel disease, such as Crohn's. Many patients are carried for years with such diagnoses before they're actually correctly diagnosed. As you heard, it is less rare now than it used to be, and some of these tumors are more malignant, as we said before, than what previously thought. They may originate in many different locations. The foregut, which is basically structures above the diaphragm, except for the pancreas, which is considered foregut, and the midgut, which is most of the small intestine and the right side of the colon, or the hindgut. All of these sites of origin help to determine the behavior of the tumor and even its possible response to drug treatment. What seems to work for a foregut tumor doesn't necessarily work for a midgut tumor. Some other interesting observations. Carcinoid tends to be multiple. About 25% of intestinal carcinoids have more than one primary tumor. There will also be associated during the lifetime of the individual with a carcinoid another cancer. It may be colon cancer, it might be breast cancer, might be prostate cancer. And this is important because it means that those with carcinoid should have very careful annual examinations looking for everything, not just carcinoid. Now, again, the incidence or prevalence of this tumor in a monstrous review of 35,000 cases that was just published in this past year, it was observed that the carcinoid has become much more frequently diagnosed. Each of the last 3 decades has seen a doubling in the incidence of reported carcinoid cases, and of course there are many that aren't reported. At the present time in the United States, 5.2 clinically significant new cases are reported per year per 100,000. Since patients with carcinoid survive a long time, even without treatment in general, that means that there's about well over 100,000 people in the U.S. walking around with carcinoid, and those are the cases we know about. Now, again, the incidence. And this shows that in the GEP, gastroenteropancreatic tract, 67% of all carcinoids arise. Then from the lung arise another 26 or 27 or so percent of cases. Those are the 2 commonest locations. A number of other disparate sites may give rise to carcinoids, very, very uncommon, but nonetheless recognized. Prostate, ovary, even the breast, for example, can give rise to a tumor, to one of these tumors. And carcinoids comprise 75% of all neuroendocrine tumors. The remaining ones, which are mostly pancreatic neuroendocrine tumors, are comprised by non-functioning ones called PPomas. They make pancreatic polypeptide, but no symptoms. That is, no endocrine symptoms. And then we have insulinomas, tumors that make insulin and cause problems with blood sugar. Then we have gastrinomas. These are tumors that produce gastrin and cause severe ulcer disease and diarrhea, and sometimes flushing too, lipomas causing diarrhea, and on down the line with other progressively rarer types of neuroendocrine tumors, all arising in the pancreas or in the intestines very adjacent to the pancreas. We won't dwell on each of these. You'll hear more about them later, except that they do share some common features with carcinoid. Now, the carcinoid syndrome is a constellation of features, both clinical and laboratory findings, which a patient having this syndrome will exhibit. And it's due to the production of excessive amounts of biologically active substances from the carcinoid tumor, such as serotonin, bradykinin, and other active materials. This syndrome occurs in only a minority of carcinoid patients, and usually those in whom there are metastases spread, mostly to the liver. There are a few rare exceptions to that, and I won't go into that at the moment. The features of the syndrome are flushing, face gets intensely red, it may be sporadic, it may stay red for a long time, diarrhea, which is anything from a minor change in bowel habit to profound pellagra in severely neglected cases because serotonin, which is overproduced by these tumors, gobbles up the precursor, tryptophan, which is also essential for the formation of niacin. And a niacin deficiency results in pellagra. Then people who have had chronic flushing will get these little spider veins on their face or their nose. Bronchospasm that looks like ordinary asthma may appear. And finally, we may get heart features, of which there are several types. You'll hear about that more later. And enlarged liver usually. And then we have minor features you see listed there. Ulcer in about 1/4 of the cases, low blood albumin, muscle wasting, intense fibrosis. That deserves special consideration. Sometimes it's tiny tumor in the abdomen is associated by lots of fibrous tissue because of some product from the tumor that stimulates fibrosis. And then we may get in certain instances chronic brownish edema and even hyperglycemia. In other words, people who have diabetes may find that their diabetic control gets worse. And those who don't may find that they're becoming mild diabetics for the first time. Now here's a picture, with the gentleman's permission, of a chap having a carcinoid flush. And you can see he's uncomfortable. There's swelling of his eyelids, and he's very red. Looking on his chest, you can see the white areas where fingertip pressure just before the picture was taken blanched the skin and showed his normal color. And then when this episode subsided, there he is feeling quite comfortable, but he still has residual redness on his face. It's sort of a raccoon-like appearance in reverse. Okay, what are the commonest features of gastrointestinal tract carcinoid? Abdominal pain first, then eventually intestinal obstruction, maybe bleeding in some cases. Maybe the first thing that is found is a mass. Patient comes complaining to their doctor, I feel a bump in my belly. What is that? And finally, carcinoid syndrome. Getting flushes or chronic diarrhea that has not been diagnosed. That's the least frequent of the symptoms presenting. Okay, for lung carcinoids, of which you'll hear more, it may be an incidental finding, just picked up on a chest x-ray, a lump in the lung. Or there may be recurrent infections, pneumonias, always in the same spot. Or there may be bleeding, coughing up blood. Or it may be that it's not discovered until there's actual metastases. Tumors are found in the liver that might be found coincidentally in the course of some other type of exam. And finally, a few cases will present with an endocrine syndrome, either carcinoid or one of the others. The lung carcinoids can cause a variety of symptoms and syndromes, for example, Cushing's syndrome. What is the course, the natural evolution of carcinoids? Well, they're usually slow growers. Those that arise in the intestine, at least 20% or so, may metastasize. And the likelihood of that is somewhat related to the size of the primary tumor when it's first found. If you find a primary tumor that's 2 centimeters or more at the time of surgery, there's a 60% chance or greater that there has been spread to a distant site, such as the liver. I mentioned before that small bowel carcinoids tend to be multiple, and that the syndrome is not that common. It's in less than 40% when the tumor arises in the small bowel. When it arises elsewhere, it's even less frequent. What are the causes of death in untreated carcinoid syndrome? I emphasize untreated because treatment with somatostatin analogs changes this. Well, cardiac cause has been the commonest in the past, with arrhythmias, heart failure, and other abnormalities. The effects of the Carcinoid products on the bowel may cause profound diarrhea with loss of electrolytes and nutriments, which weakens the patient, and consequently we may have infection, we may have shock, we may have bleeding, a variety of things that result because of the profound diarrhea. And then only 25% in the undiagnosed or the untreated cases will actually have extensive distant spread and die because of this generalized cancer process. That was without treatment. It has changed with treatment. It has changed in that all carcinoid patients, whether their tumors are functioning or non-functioning, tend to die eventually from spread of the tumor, not so much from carcinoid syndrome, for example. Okay, again, what helps us to tell about prognosis, the outlook? The primary site of the tumor has some bearing on this. The appendiceal carcinoids are almost benign. Only a few of them spread and really cause problems. The rectal carcinoids also are less serious, although a few will spread. Then the lung, then the gastrointestinal tract, and then the pancreas, in that order. Again, the size of the primary tumor is important because that predicts the likelihood of spread. The depth of invasion of the supporting tissues. I showed you that first slide of the little cross-section of the tumor, and you saw that it invaded through the full thickness of the bowel wall. Well, that has this very serious meaning. It has to be treated like a regular cancer, except bearing in mind its slow motion. And if it's gone through the whole bowel wall, there is a risk that it has spread more distantly and perhaps only microscopic, but it means that there is a chance for recurrent disease. Also, there are some histologic features looking under the microscope that make a difference, and I won't go into that right now. Treatment or carcinoid syndrome tumors without treatment have a worse outlook than those who don't have the syndrome. But now, as I said, with the use of the somatostatin analogs, we control the syndrome, so the outlook is roughly the same. And again, there's wide variation. Okay, diagnosis, you'll hear more. I've divided that into 4 features. One, the most important, is to suspect it. There has to be an awareness. If you don't suspect it, you can't detect it. The theme song of this meeting. And suspicion is very important. We can do markers then, chemistries, that will help tell us serotonin, chromogranin A, urine 5-HIA. Even in the non-functioning ones will be up a little. Imaging, various x-rays, Trio scan, and then finally prove it absolutely with a biopsy. And here are the markers I mentioned just a moment ago. And here are the listing of all the standard x-ray imaging. The Trio scan, of which you'll hear, is the gold standard and the best way. And finally, treatment. Well, there are 3 categories of treatment. Each one has to be customized to the patient. Sometimes they're all done simultaneously. We have to do supportive treatment, which may be anti-diarrheal treatment, of which a somatostatin analog will be the major keystone. Nutritional measures, replacement of electrolytes and other important nutriments, ulcer treatment, and maybe some anti-fibrosis treatment. Surgery, there are many roles. Biopsy for the diagnosis is most important. And the overwhelming fact is that at present, the only cure that we know of is to take it all out completely surgically. We can deter progression, prolong survival with many other measures, but surgery is the mainstay of treatment, and earlier, the better. And then finally, anti-proliferative treatment. That includes biotherapy, that is non-chemotherapy, such such as octreotide or lanreotide, alpha interferon, radiotherapy, external beam, or injected internal radiation, both systemic and targeted to specific organs such as the liver, and then finally chemotherapy, using the standard drugs that we've known of for some time. They have a small incidence of beneficial response, but if you happen to be one of the fortunate ones who's responding, that's great. That's good for you. You're 100% responsive. And then we have new agents which are being developed. And so, again, I'm just emphasizing here the somatostatin analogs and their importance. And this is more figured to show what effect they've had over the years from pre-somatostatin analog therapy, or times, a 5-year survival of 18%, and now a survival 5 years of 84%, all since the introduction of that group of drugs and more aggressive surgery, more aggressive chemotherapy, and supportive measures. And this just shows us a cartoon of the complexity of a cell with all of these different structures, each one serving a function that helps the cell replicate. And here, much simpler than a cell, is the inside of a clock. And you see a forceps holding a tiny grain of sand, and if it was dropped into that mesh of cogs and wheels, it would grind the whole thing to a halt. And so the development of molecular engineered drugs to interfere with those, even one of the vital functions of the intracellular structures that are necessary for carcinoid tumor replication, will help to prevent the replication and slow down the growth or even stop it. And that's what's being developed. And finally, in conclusion, again, a complete and permanent cure is can only result from surgical resection at the present time, but palliation and survival benefit do come from customized treatment in each case, with early aggressive surgery and sequential treatment with different modalities, whether it be chemotherapy or radiotherapy, and you see them listed there. That all prolongs survival. The only thing we don't have a definite timetable for yet is when to apply which of these modalities and in what order to apply them. That is developing, and each of us who works in this area has our own criteria for making such choices. I thank you.